Please start.
Okay. Yeah, so good evening, everyone. On behalf of Bayer, I would like to welcome you all for today evening meet, Eyesight Update in AMD. And to moderate today meeting, I would like to invite Dr. Santosh Gopi Krishna, sir. Sir is a senior VR consultant at Narayana Netralaya Hospital, Rajaji Nagar branch. So with this note, I would like to hand over the session to Dr. Santosh, sir. Over to you, sir.
Thanks, Avinash. Good evening, all. Today, we'll be discussing a few points about Eylea, especially exploring the unique molecular features and the durability of action and when compared to other molecules. And we can have a informal discussion as how to each one of us are using Eylea. So we have our speaker today, Dr. Anupama Kiran Kumar. She's a senior retina surgeon at Narayana Netralaya Indiranagar branch and a friend and colleague. So she'll be talking on evaluating the need for need for change, evidence, and insights on anti-VEGF therapies. We also have Dr. Dakshayani and Dr. Vaishnavi Rao. So thank you, ma'am. Dr. Dakshayani is a senior VR consultant at Vijaya Netralaya Hospital, and Dr. Vaishnavi Rao is a senior VR consultant at St. John's Medical College. We also have Dr. Saurabh. We'll be having a discussion on these topics, and over to you, Dr. Anupama. Maybe I think you can start the presentation and later we can have a discussion.
Thank you, Dr. Santosh, for that introduction. I'll just be sharing my screen. Good evening, everyone. At the outset, I'd like to thank Bayer for this opportunity. Now, in a world of multiple anti-VEGF therapies, today I'm going to look a little bit at the real-world switch data to see whether actually a change is really evidenced and required in a scenario where we already have well-established molecules. So let's look at the real-world data, and probably we can discuss a few cases and we can discuss our experiences. So I'm going to dive into it. As far as anti-VEGFs are concerned, of course, our generation can be actually said that we are spoiled for choices. We have multiple choices, 5 really commonly used molecules. And it is an unequivocal fact that anti-VEGF therapy is the therapy of choice in neovascular AMD, as well as the fact that neovascular AMD responds best to early anti-VEGF therapy. Now, having said that, we have not been able to really really replicate the study results as far as our real-world scenarios are concerned. And these have multiple factors, of course, including inter-individual variabilities in responses. Variability in responses based on the age of the patient, the type of lesion, the duration of disease. And of course, there is no agreed consensus on what is considered an optimal response, or for that matter, what is the lack of it. So this really pushes our hand towards changing, switching, and all of these things. But we really need to look at the evidence if it supports this kind of change. Now, before we discuss why we change, how we change, let's discuss what we talk about as response. So there are 2 types of response: the primary response, which is at the end of 3 loading doses, and a secondary response, which happens anytime after the 4th visit. Now, a secondary response has the primary response has no bearing on what the secondary response would look like. And this is one of the challenges that we face. Now, we evaluate responses based on 2 major things. One is the visual acuity, of course. And this might not always be feasible, considering there could be certain challenges. And along with that, we also use the OCT morphology. We do use ICGA in certain cases, but mostly the morphology and the visual acuity are our drivers. Again, response is divided into anything between good, partial, poor, or non-responders, comparing morphology with function. However, a lot of times, morphology and function may not actually go hand in hand. For example, you may have a patient with really poor vision and a completely dry retina, which, mind you, is a very different patient from a patient with poor vision as well as a retina with fluid. And a lot of times, scarring and outer retinal tubulations and changes like that could look like a poor response, but actually not really evidence of poor therapeutic response. They are just how the disease progresses. Now, coming to the fact of switching. Now, is switching really the hope that it's claimed to be, or is it just hype? The only way to analyze this, or rather support this, is to discuss what the real world evidence looks like. So these are a couple of real world studies. Here, on all of these studies, patients with neovascular AMD have been switched from aflibercept to faricimab. And as you can see across board, the gains in visual acuity in these switch patients have been minimum, and a lot of times not visually significant either. The real change is the real good vision is seen. Visual gains are seen in patients that are treatment naive, and that was not the aim of the study in the first place. So the switch patients are not really benefiting as much as they claim to be. This is another study where 130 eyes were actually switched from aflibercept to faricimab in neovascular AMD. And again, you can see that 60% of this cohort actually discontinued faricimab treatment, a majority of it basically due to insufficient efficacy of faricimab. And 73% of this group actually switched back to aflibercept. So not really, again, switching is not really the magic pill that it's claimed to be. We have neither achieved visual gains, nor have we had any kind of significant changes in central retinal thickness. And as a matter of fact, the treatment has not been pushed beyond Q8 either. So not really reducing the treatment burden. This again is another study with about 55 patients, again switched from aflibercept to faricimab. And again, you can see 70% of these patients have not crossed the treatment interval of 8 weeks. So the claims that probably a different molecule would reduce the treatment burden, not really happening here. This is again a head-to-head comparison. I'm not going to go into too much detail on this, but you can see that the visual acuity gains for aflibercept significantly better than that for faricimab. Now that we have not been able to really prove the functional benefits of actually switching a molecule, could targeting an additional pathway really be what is the treatment change required? Let's look at that. And we're not the first to do it either. Take brolucizumab, for example, a higher molar dose, smaller antibody fragment, or you have an additional pathway as in faricimab where you have the Ang2 pathway, or you have a different mode of delivery as in the surgical implants. All of these have been used, have been tried, have shown some efficacy, but have not really shown that clear efficacy win that we're looking for. And as a matter of fact, a lot of these things have also run into safety concerns, which is another very important thing for us to look at. Adding an Ang2 inhibitor. Now, is it really that effective? It's been tried with aflibercept. And if you can see the data in the Onyx as well as the Ruby studies, both for neovascular AMD and DME, the visual acuity graphs are actually running head-to-head right up to 36 weeks, showing that adding an Ang2 inhibitor is not really adding to the efficacy of an already pre-existing molecule that has shown efficacy all through. So this additional step is not really serving us too much. The claim to fame for faricimab was exactly this, adding an Ang2 inhibitor to an existing Fab fragment. The Fab arm of this is actually very similar to ranibizumab. And additioning of the Ang2 was studied in these studies, which were the Tenea, the Lucerne, the Yosemite, the Rhine. And the important thing to keep in mind for these studies, and all of them across board, is the fact that they are considered non-inferiority studies. Now, that is the key word, which means that adding this additional fragment to the existing molecule is not really giving you a benefit over the pre-existing molecule of aflibercept. It is just making it equal to it. So adding for equality doesn't again make too much sense. Similar comparison of ranibizumab against faricimab. The suppression of Ang2 in this particular study was not shown to be different in faricimab versus ranibizumab. Basically, adding to the fact that a downregulation of VEGF is actually also causing a downregulation of Ang2, and adding this extra arm is not giving it an additional downregulation of Ang2. Both are essentially the same. And I think the FDA also echoes the similar sentiments, which brings us to the VEGF receptor pathways, and that's the master regulator. So how does our primary fragment work there? Now, when you talk about the VEGF pathway, hypoxia causes the release of VEGF and placental derived growth factors. Now, the placental growth factor acts on VEGF1, the VEGF-A acts on VEGF2. We're all quite familiar with it, and that brings out the cascade. Aflibercept across board blocks both of these receptor ligands, so causes a broader blockade and pretty much covers all of the VEGF pathway molecules. Therefore, the effect remains the same with that single molecule. So to summarize, I'd say that the 2 milligram aflibercept that we already have is already a master regulator, does not really require any tweaks, and changing a molecule does not really add value. However, increasing the molar dose of the existing molecule could have a potential effect in extending the efficacy of these molecules. And the recent PULSAR as well as the PHOTON studies suggest that the aflibercept 8 milligrams has a potential for a greater long-lasting control of the underlying disease compared with the aflibercept 2 milligrams. So that is something to look forward to. It is something that would help us keep a sustained disease control. Now, I'm going to discuss a few of my cases. They're very basic cases, nothing out of the blue, but this is just to drive home the point. So I'll start with a very classical case. This is what I would call the case that is the rule. Most anti-VEGFs work pretty well, and in neovascular AMD, in my experience, Eylea works beautifully. So this is my patient at presentation. The vision in one eye was counting fingers 2 meters, the other eye was 6.6. This eye had a CNVM, the other one had drusen. Now, this was a 71-year-old male, and I started with Eylea. Post the 3 loading doses of Eylea, this is my patient. Visual acuity, as you can see, has improved to 660. And if you look at the lesion, there's a good consolidation of the lesion. The intraretinal fluid has resolved. There is no subretinal fluid. So this is a good morphological outcome and a decent visual outcome as well. Now, this patient sustained really well. And I have sustained this patient for over a year now at this particular structure with a good consolidation of lesion. Vision has improved to 618 over the period of 7 injections and 1 year. And this is what I would call the rule or a classical patient. So this doesn't really, shake me in any way. I give a drug that I trust and I have trusted for a long time. The patient has responded well. Everything goes good. The lesion looks better, so I feel better. The vision is better, so the patient feels better. However, all of these cases do not present the same way. And sometimes you have slightly different looks. And of course, the patient also behaves slightly differently. So this is a case of an 83-year-old man. Vision in both the eyes is 6.6, mind you. So now comparing vision changes, unless we are losing vision, is not really what we are looking at. So we're going to only look at the lesion here. So the left eye had a PED with SRF at the macula, and these were the FA-ICG pictures. As you can see that there you have the classical hotspot, which with the occult leak, and this is the case of PCV. As you can see the notched PED there, and you can see the subretinal fluid. The patient had a baseline visual acuity of 6.6, terrifying for us because now we have a lot to lose. We started with Eylea here, and after the first injection, the patient showed a resolution of the SRF with a minimal reduction of the PED as well. Continuing on, the patient, of course, was lost to follow-up, and that was for 5 months. Patient presented back, and this was the picture. This is where we gave our second dose. Vision had dropped to 6.8. Post the second dose, the patient was again lost to follow-up and came back again 5 months later. If you notice, the PED is actually slightly smaller still, and you do have SRF, of course, but not as bad as we would have anticipated. After this is where the third dose was given now, and this was the patient after the third dose, 1 month post the third dose. Here you can see a significant reduction in the PED now, and because of the collapse of the PED, you can see that cavitatory space, not necessarily subretinal fluid. Now, here we're not seeing that dramatic structural flattening that we would love to see. And the vision acuity is though maintained, so that's a good thing. But this kind of makes us antsy. But we continued on, and patience, I think, is key in such cases. So this is 3 months post the third dose because the patient did not come back again. We gave a fourth dose, 1 month post the fourth dose. And this is the patient 1 month post the eighth dose. Now here you can see there's a significant reduction in the PED. There are some cavitatory spaces, not too much SRF. I would say structurally it is doing well. But it is the kind of cases where you want to try multiple things to see whether you can get complete flattening, whether you can get complete dryness. That, in my opinion, is not necessary. And I'd love for Dr. Santosh to comment on this once we are done. This is just to show you the comparison of where we started. We started at baseline with this PED, with this SRF and 6.6 vision. We are at 6.9 vision. We are with a decent flattening of the PED, not really any active fluid. And the patient has lost about 1 line of vision despite pretty erratic treatment. Is this considered success? Is this considered failure? I'd love for everyone to chip in on this. This is the case. This is the third case. And this is a pretty traumatic case for me personally, because this is a one-eyed patient. Patient presented to me with one eye, this scarred CNVM, and in the left eye, the patient was had an active CNVM with multiple anti-VEGFs already. So this was after 3 doses of ranibizumab and 1 rather traumatic dose of brolucizumab as well. If you look carefully in the posterior vitreous, you can see a little bit of cellularity even in this particular image. You can see clear-cut evidence of activity, including the intraretinal fluid. And this is where I stepped in with Eylea. And after one aflibercept itself, you can see that the patient has significant reduction of the lesion, consolidation of the lesion, along with a reduction in the intraretinal fluid. Here, the patient's visual acuity had rapidly improved, as a matter of fact, right up to 660. She had started at counting fingers, and you can still see the persisting cellularity from the previous brolucizumab. I continued to maintain the patient on Eylea, and I could not really extend her treatment beyond 6 weeks at any point of time. So I was continuing with the treatment, but the vision had improved to 618 at this point of time after 6 months of aflibercept. After 12 months, however, the disease took a little bit of a different turn, where you can start seeing that the intraretinal fluid is increasing, the lesion size is increasing, as well as you have some amount of subretinal fluid. The patient's vision now dropped to 624, and this is where I panicked. I don't feel ashamed to say it, because, like I said, it's a one-eyed patient, and any change in vision is, of course, concerning both for the patient and for the treating doctor. At this point of time, I decided to do a knee jerk and switch over to to faricimab, and that's what I did. So I chose to switch, and as you can see, this was faricimab, post-faricimab. You can see a significant increase in the IRF at this point of time, and the patient's vision dropped to 636. I tried a second injection, considering that I wanted to give the molecule the benefit of doubt and try just one more. Did not work. And at this point, I went right back to my trusted aflibercept. And post 1 month of the switch, patient's lesion reduced a little bit. The fluid started to respond again. I'm not really sure why, but it did. And this is how it was post the second aflibercept at 618 vision. And I've continued to maintain this patient, albeit at probably 6 to 8 weekly intervals maximum, but the patient is maintaining a vision of 618. Then, mind you, we started at counting fingers with a one-eyed patient who pretty much cannot be put on any other molecules. So I think that at this point of time, I'd like to conclude by saying that we do have a great molecule that really works. The evidence to switch, albeit has been presented multiple times, is at best shaky. I think the decision to change should be made only in cases of solid evidence. And at this point, I'm not really sure if that exists. Thank you.
Thank you, Dr. Anupama. Those were excellent cases and a nice sum up of what exactly aflibercept is and when compared to other molecules. So, like when we have these molecules now at hand, like the higher end molecules, it's obviously a little difficult to kind of stick to one. We do kind of tend to change especially in case of recalcitrant cases and all. But whatever said and done, aflibercept has been the mainstay, and it's a comparator molecule even in the real world studies, or even the the clinical studies. If you look at it, that's a base molecule. That's a comparator molecule to which all the new molecules are compared to, and it's been my treatment of choice. I mean, it's a first line of therapy for me most of the times. So, looking at your cases, I just want to kind of comment on the second case, which is a very difficult case to treat, especially the PD, and that kind of SRF that kind of is tough to treat. So the PD most of the times it's very difficult to kind of settle down. So as long as the PED is there, I mean, obviously we are not treating the PED, but the height of the PED, when it fluctuates, we know that there's an activity that's going on sub-RPE. So then that itself means that the activity is still on. So we don't know how to kind of end it and where to end it. So I believe that is a time wherein treat and extend comes into play. So I would like to ask you, I mean, how often do you kind of use the treat and extend in your regular practice?
To be honest, Dr. Santosh, I don't do treat and extend on a regular basis. I do save it for patients who are specifically one-eyed patients, especially if I extend the first time and I see a recurrence in activity immediately, say at a 6-week interval, then I switch them over to treat and extend. But if I see that I can push my treatment regimes to 8 weeks and then come back off and on, that doesn't really push me to go into a regular treat and extend regime. I tend to do what is called as extend and observe, which is basically PRN in a more structured manner.
Yeah. Your take on it, Dr. Dakshani? I mean, how often do you kind of extend these cases? I mean, do you kind of do a personalized treatment interval or like do a PRN, or you kind of
I
convince the patient to extend the injections by 2 weeks? How do you?
no, so I usually
Yeah, ma'am.
follow PRN regimen itself because, like, with the cost and the
Okay.
financial factors, it becomes difficult to convince the patient to treat them on a regular basis. So, if we show them the evidence that there is fluid and you need treatment, they're more convinced for treatment rather than just telling that we'll keep injecting every
Right.
6 weeks or things like that. So.
Okay. Dr. Vaishnavi's take on it?
Same way, sir, like how Dakshani ma'am highlighted, it would be personalized depending on the cost constraints of the patient. But like you said, sir, second case, I would feel treat and extend would have worked better. Like,
Okay. Yeah. And anything, looking at the pathology, you kind of decide that, okay, this is the molecule that I would like to stick to. I mean, how often do you use aflibercept in your regular clinical practice, and in what cases? I mean, I think maybe you can take it one by one.
I'll go for it first. Most of the time for wet AMD and for PCV
Yeah,
cases,
ma'am.
I usually choose aflibercept itself, unless the patient, and especially when the patient has a tall PED more than 400 microns, we emphasize on to try to push the patient for aflibercept itself. Unless the patient is not affordable, we have to take that step back and then go ahead with ranibizumab biosimilars or something like that. But most of the time, till now, it has been aflibercept as a drug of choice. But now, since the vials have been withdrawn, it's like we are forced to convince the patients to go to faricimab. As of now, it was aflibercept itself, sir.
Achha.
And in DME cases,
Okay.
again, my drug of choice, first I usually start with the biosimilars and then switch to aflibercept if the patient is affordable.
Okay. Okay. Yeah, I think the ad was a really good thing. And even, but now I think with the reduction of price also, like I think it's a good thing that the price is almost half, kind of a thing. But the next thing is the ITMG, what we would be looking forward to. But whatever said and done, I mean, if in my practice, usually like if there's a suspicion of a PCV or wherein I want to play safe, so I mean, Eylea is a drug of choice for me. So fast, it like sometimes works. There is a kind of a thing wherein we try to kind of switch over in recurrent cases, as Dr. Anupama had shown. So, but most of the times, again, we tend to come back to the parent molecule. Dr. Vaishnavi?
sir, in my practice, I have very limited experience with faricimab, but for
Yeah.
PCV and wet AMD cases, I would always prefer Eylea. But like ma'am highlighted, since the cost constraints and because of that, sometimes I do have to switch back to biosimilars. But in such cases, I would always prefer Eylea over other biosimilars, sir.
Yeah.
So I think
Any experience from the yeah.
I think as far as the cost
Go ahead.
factor is concerned, initially we had, of course, the patient support program, which was great for us. And that's how a lot of our patients actually got the benefit of the drug. And eventually, I think that the drop in price, like you mentioned, is a major factor in being able to convince the patients to a molecule that we would like them to have. And at this point of time, I have not encountered too many issues with my patients wanting or not wanting this drug, because it's not monumentally more expensive than the other drugs in the market. And it definitely has a much better benefit, and I'm able to convincingly talk to my patient about it. So I think that I always choose, especially in wet AMD and PCV, Eylea would be my first choice.
Yeah. This is, I think it makes sense. I mean, many a times, the first case of CNVM, what you showed, is obviously most of the time those are straightforward cases what we can treat. But once it gets a little recalcitrant, I think we tend to kind of jump to these molecules. Any questions from the guest, the participants. I think Dr. Aditi, I can see. Vignesh.
Is there any experience with Ziv aflibercept at NN, sir?
Okay.
So do you have any experience with Ziv aflibercept at NN?
No, ma'am. We don't use it here. I believe I think LVP was using it.
Yes, sir. They
No, ma'am, no. We never used it here. So far none of the branches have used as aflibercept.
okay, sir.
I believe LVP had used it. They
Yes, sir.
even
Dr. Rajan.
papers.
Yes, sir.
I think it has its own chassis. Yeah. I believe what you call a really tight PED flattens over a period of time, and the control what you have over the pathology is it's really good. I mean, you know that nothing's going to really go wrong. So I've had cases wherein there was a breakthrough hemorrhage because of PCVs. So those are the cases even where I had safely injected aflibercept. And like, I mean, the result is so what do you call predictive. I mean, you can really know that, okay, there's nothing really that's going to go wrong. And the action also, like I've seen in 1 week or 2 weeks time, even the tall PD time kind of gets flattening. But one thing I would really want to say is sometimes we can't decide on the treatment response just based on injection. Sometimes after second injection is wherein these tough cases, they kind of start loading dose as we all regularly use. That's a way to go. And I think then we can take a call of how to go about. So I believe from 3 doses nowadays, in some tough cases, it's safe to even extend to 5 doses. So that, I mean, the disease pathology really kind of. I really prefer Eylea is vein occlusions. So though it could be off-label, but it really works well when there's no other treatment that really works. Even Ozurdex also. In cases wherein especially BRVOs and CRVOs, one injection, sometimes you get a treatment-free period for almost 4 months, 6 months and all.
Correct.
It's a beautiful
Yeah,
drug
almost 16
in
months.
those cases also. I think, yeah. I think any other
How about
questions
PDT?
or
So,
anything
like,
to discuss?
you've started using PDT, so now the dye is available again. So have you started using PDT, sir? Or?
Not yet, ma'am. Actually, the thing is, I was speaking to Dr. George. So Arvind, they're coming out with the drug. So I'm not sure whether when officially completely it will come out. So, but here at NN we haven't really officially available. So yeah, once it comes, especially these recalcitrant ones, once you do an FAICG again and then you see where the activity is, that could be sometimes really helpful. But as many studies have already shown that the anti-VEGFs itself are good enough for the polyp closure, inactivation, or complete closure of the PCV. So sometimes anti-VEGFs itself is enough, but I believe most of the times we need to kind of be a little vigilant and repeat the FFA-ICG so that we get an idea what's really happening to the pathology rather than just going on injecting. Maybe at
So
the end of loading dose, it really makes sense to kind of repeat an FAICG. Yeah.
you still follow that laser to the polyp procedure,
Yeah, ma'am,
sir?
you're saying something.
Okay. Thank you, sir.
No, I do it only when it's extramacular. Especially most of the times, I've done laser to peripapillary polyps. So when it's
Okay.
in and around the disc, that is the time where it really helps. But especially when it is closer to the macula, and when so much of things are going on at the macula, it's a little difficult to kind of get the nerve to go and do laser there. So yeah, peripapillar is a safe thing wherein you can really do. But if you feel once you have done a loading dose and you've extended it and you feel that it's a recurring disease, I think that is the time when you repeat an ICGA. Most of the times these polyps do close by spontaneously also because of thrombosis, or sometimes with the treatment as well, most of the times. So new polyps and new BNN can occur. BNN and the CNVM net, it doesn't go, but these polyps keep changing. So sometimes I have lasered, done a focal laser over this BNN, especially when it's a large, complex, little extra foveal. So that also sometimes helps, though it's a little desperate move to kind of have no recurrence. Yeah.
Okay.
Yeah. I think there's nothing else. Any more questions or anything from you, Dr. Anupama?
No, I think we've covered most of it. Thank you.
Yeah. So DME again, anyways, we know that it's not a time-bound thing. So yeah, it does. I mean, we have an armamentarium of these anti-VEGFs, but yeah, once we know that which kind of DME really responds to what kind of anti-VEGF, so I think it makes sense. Sometimes we can switch or go for the higher higher molecules as well. So yeah. So I think if there's no more questions, I think we can end it. It's 8:05 already. Avinash?
Yes, sir. I think
Okay, no power,
if
no
there is
place. So the Wi-Fi,
okay,
everything is down.
no problem, sir. So I think there is no questions, sir. So can we close, sir?
Yeah. So I think the network is a little wonky. Yeah.
Okay.
Yeah.
Okay, sir.
Yeah,
So
we can. So I would like to thank Dr. Anupama and Dr. Dakshani and Dr. Vaishnavi for that participation, and all the attendees also. So thank you so much. We had a good discussion here. So over to you, Avinash. I think you can end the session.
done, sir. Thank you so much, sir. Thank you so much to everyone once again from our side, and good night to all.
On behalf of Bayer, thank you, Dr. Santosh. Thank you, Anupama ma'am. Good night. Thank you.
Thank you, Mr. Sharma. Thank you, Avinash. Thank you, Dr. Santosh.
Thanks, BP. You are not seen.
Thank you, everyone.
Thank you, ma'am.
Thank you everyone and good evening.
हाँ सर, बाहर हूँ इसीलिए नहीं
वीडियो
आ
ऑन
रहा
नहीं
हूँ।
किया.
सर मैं बाहर बैठा हूँ कहीं पर इसलिए।
Thank you.
हाँ, थैंक यू डॉक्टर सर, थैंक यू।
ठीक है. Just pulling your leg. Thank you. Thank you all.
Yeah.
We'll catch up, guys, sometimes. All of you. Thank you.
RIC में मिलता हूँ सर आपको।
हाँ, अच्छा आ रहे हैं आप. ठीक है,
हाँ
मिलेंगे
मैं आ
फिर.
रहा हूँ सर, I'm coming.
ठीक है. Bye.
Bye.
Bye, sir. Thank you, sir.
ठीक है. See you. Bye.
Yeah. Bye, sir.
Bye. Thank you.
Sir, can we close the session now?
Yeah, you can.
Okay, sir, we are ending this session.
Yeah.